Take note of the nearest exit in the event of an emergency, and there's some useful conference crew staff around to help us out. And if you need any assistance at any point, just see the registration desk, and they'll be able to help you out, the conference team there. And just a quick plug for this after morning tea, after lunch session in here about making it as an allied health researcher in the world of intensive care. We've got a great panel, and we're hoping to just have a good discussion, and hopefully we might all pick something up. But that's this afternoon. Let's get started.
Thanks, Simon. Our first speaker is Dr. Claire Baldwin. Claire is a clinician, researcher and teacher who obtained her Bachelor of Physiotherapy from the University of South Australia in 2005 and a PhD from Flinders University in 2013 on respiratory and peripheral muscle dysfunction and critical illness. Her clinical and research experience is mainly focused on physical function in the ICU and the acute phase of recovery, with a particular interest in helping people with sepsis or who require prolonged mechanical ventilation. Most recently, Claire has been supported by a Physiotherapy Research Foundation grant to study physical activity and sedentary behaviours in the ICU, extending her interest in outcome measures. As an early career researcher, she has 14 peer-reviewed publications, a book chapter contribution, and experience at presenting as both an abstract author and invited speaker at national conferences. Professionally, she has served as the president of the South Australian branch of the Australian Physio Association from 2012 to 2013 and is currently the South Australian representative for the National Cardiorespiratory Group of the association. She's clinically affiliated with the Flinders Medical Centre here in South Australia, and today Claire's going to speak about the associations between body composition and weakness and functional limitations, a cross-sectional study of bioelectrical impedance spectroscopy in mechanically ventilated adults. Thank you, Claire.
Thank you, and I think I'd rethink the length of that title for any future presentations of this work. Either way, it's a pleasure to be in this session today and to present on behalf of the project team, who I'll tell you about in a minute. Skeletal muscle health is vitally important for patients' physical function. In the ICU, the loss of muscle mass is rapid, and the changes that many patients experience are often acute on chronic. One method for body composition analysis is bioelectrical impedance spectroscopy, or BIS. Bioimpedance has been used as a tool for fluid and nutrition assessment in the critically ill, with some parameters also being associated with length of stay, illness severity and mortality. But what about muscle health? We only know of one study to relate bioimpedance parameters to muscularity in critically ill patients. Both the phase angle and the impedance ratio were predictive of low muscle cross-sectional area as measured by CT. Bioimpedance is advantageous in that it's done non-invasively at the bedside, it's relatively inexpensive, and measurements are repeatable. Maybe there are associations with patients' actual strength and function beyond muscle size. Maybe we can add value to bioimpedance as a methodology, especially when thinking about how measures from early in a patient's admission might help us understand their outcomes down the track. Mainly thanks to Selena Parry, this is the research team that was purpose-built for the project. So as physiotherapists and dietitians, researchers and clinicians, we are impacted by the problems of our patients' muscle health. We saw the opportunity to collate our data and knowledge to progress this field forward. So we did this through a retrospective analysis of prospectively collected data, with the aims of describing and comparing body composition in critically ill patients who required mechanical ventilation at our respective centres, and then to examine relationships between bioimpedance data and patients' muscle strength and physical function. So the sites were the Royal Brisbane and Women's Hospital in Queensland, Flinders Medical Centre here in South Australia, and the Royal Melbourne Hospital in Victoria. But the data actually came from 4 separate studies. 3 of these were cross-sectional and 1 was a double-blinded RCT. 2 of the studies specifically recruited people with sepsis syndromes. So from all of the studies and sites, the total pool of participants that we had was 148. Of course, each individual study had its own inclusion and exclusion criteria, but after screening out people specifically for this study, we were left with 136. So that was 60 from Melbourne, 32 from Adelaide, and 44 from Brisbane. Essentially, they were adults who required at least 48 hours of invasive mechanical ventilation, had an actual or anticipated ICU length of stay of at least 5 days, They were able to walk at least 10 metres in the previous 3 months, and they had bioimpedance data. We looked at data cross-sectionally, and as you'll see, it's a bit patchy with regards to what each site had. Still, the Victorian and Queensland sites had their bioimpedance data at enrolment, which was within 48 hours of ICU admission. Data from when people were first awake in the ICU came from my South Australian and the Victorian samples. At awakening, muscle strength was measured on the same day as bioimpedance at my site and within 3 days at the Victorian site. And as you'll see in the results, perhaps this discrepancy was too great to find a signal when we pulled the site data. Then there were a range of follow-up strength and functional measures at both ICU and hospital discharge. The main reason this study was possible was that all sites used the same model of device, the SFB7. It's where a weak alternating current is passed through the body, and lower frequencies will pass extracellularly and higher frequencies will penetrate intracellularly. Cole modelling of raw impedance variables, it will give you impedance variables, that are prediction independent of prediction algorithms. But when you do use prediction algorithms, you can get estimates of fat and fat-free mass after the estimation of fluid distribution between the intracellular and extracellular compartments that adds up to total body water. Muscle strength was assessed at all sites with the MRC sum score, where scores from individual muscle groups are added up to get a score out of 60, and higher scores are better. Physical function was assessed at all sites with a physical function in ICU test. Patients are scored on 4 tasks, and again, higher scores represent better function. So now the results. These are the sample characteristics for which there were no differences between the different sites. The median age of participants was 59, of whom 57% were male. Apache and SOFA scores suggested at least moderate illness severity at admission. The median BMI was 27.8, but nearly 75% of the sample were actually classified as overweight or obese. As for nutritional needs and risk, there was no difference in estimated energy requirements or Nutric score. There was also no difference in the presence of ICU-acquired weakness at awakening. But there were some site-to-site differences that may still have impacted the subsequent results. The most obvious being a more prolonged duration of mechanical ventilation and length of stay in the SA sample that mainly related to the original study's sampling criteria, whereas the Victorian site had the shortest durations of ventilation and ICU admission. But now for the data that actually addresses the primary aims. I'm starting by comparing the Victoria and Queensland bioimpedance data that was obtained within 48 hours of ICU admission. There were no differences in fat mass or fat-free mass as a percent of body weight. There was no difference in total body water as a percent of body weight. And while we might expect patients with sepsis to have an extracellular fluid excess but be intracellularly dehydrated, the septic patients from Queensland actually had a greater proportion of intracellular body water, a median of 52.2%, compared to the Victorian sample. In terms of associations, this is a reminder of what data we had. But there were no associations between bioimpedance variables from enrolment with muscle strength down the track at awakening or at ICU discharge when site data were pulled together. But on site-by-site analysis, greater fat-free mass was weakly associated with better function at ICU discharge from the Brisbane site, a Spearman's Row of 0.333. If we move along the recovery timeline, this slide compares the bioimpedance data at awakening from Victoria and South Australia. My SA sample had more fat mass, 39 versus 25%, and less fat-free mass, 60 versus 75%. They also had less total body water, not just compared to the Victorian site, but when I also looked with reference to healthy matched controls, so they were an exceptionally dry patient sample. Then, similar to observations that we saw at enrolment, the SA sample again had a greater proportion of their total body water in the intracellular space. In terms of associations at awakening, bioimpedance variables were not associated with concurrently measured muscle strength or physical function at ICU discharge when using the pooled data. But on site-by-site analysis, a greater proportion of total body water, remembering these were very dry patients, with more fat-free mass and less fat mass were associated with better muscle strength and physical function, especially at hospital discharge, with row values of 0.733. So we're in the situation of trying to understand why there were associations with some variables and not others. I've touched on some cohort differences, but maybe our procedural differences were not so minor. We can only reflect on whether aspects like body weight and height measurements or the body position for testing were actually rigorous enough. Or it might have reflected whether data were read directly from the device versus taking additional steps in post-measurement software processing. Variations might also be attributed to our standard nutrition and physiotherapy care, which we were unable to describe retrospectively in a consistent way across the studies. We know that practices for fluid management are vary hugely in Australian ICUs, and it might be that fat-free mass, rather, is not so much a proxy for muscularity, but reflects other fluid and tissue health parameters. Ultimately, we're only looking at associations, but changes over time might better correlate than these cross-sectional measures. Despite all this, there were associations from the Queensland and SA sites that sampled quite specific clinical groups, with some astoundingly strong associations. We're working through some additional analysis with raw impedance data that might help us identify other variables to predict patients' functional outcomes. But in essence, I think that we've added to knowledge in that we've found some signals that make sense in the light of data from other research studies. We've outlined the potential for variability across sites and cohorts that might need to be considered, probably would need to be considered in future studies. And finally, we're the first people to investigate associations between bioimpedance data and the actual strength and function of critically ill patients. So thank you all very much, and to my project team.
Thank you very much, Claire. Are there any questions?
Thanks, Claire. I just had a question about the method that you used. Obviously, with bioimpedance spectroscopy, the regression equations are based on patients that are normally hydrated. So I guess I have concerns about the measures with the fat-free mass that you reported, and how can you, I suppose, did you collect any other data in relation to the patient's fluid status? And
No, we didn't, and we found that hard across sites. So individual sites may have, but not in a sense that we can pool it together. My understanding of the fluid issues are that they're particularly bad for patients that are horribly overloaded, and we're talking about patients here that are actually mildly underhydrated. So it's a bit of a tricky diagram, but when I looked, for example, for my cohort, which is the only group that we've got some of this raw impedance data, which takes out the problems with the modelling, and we look at their fluid status. Using this method, we've actually got ICU patients that have got less fluids, but it's not horrible. So I think you could expect essentially the validity to be maybe okay. The other thing is when we looked at the ECF to ICF ratio that does rely on that prediction modelling, for our patients at least, and from the Queensland site, that was actually closer to a normal ratio in a normal patient. So that gives me some confidence that despite all the limitations of the technique, actually that it might not have been too bad. So that gives me some confidence, but I agree with the grain of salt that you need to take.
Sorry, I might have missed this, but I'm really interested to see your raw impedance data. I think that'll be...
Would you like to?
Yes, please.
Yeah, it's a bit messy. We haven't tidied this up yet. Yeah. So I guess when you take that stuff out, you have got things like, phase angle that was associated. This is just from my site because it's the only site that we had it from. Sorry, everyone else from Melbourne and the Queensland sites. But yeah, we can look at phase angle. We can look at things like this characteristic frequency, which is where we think that the peak of that curve on that cold modelling might be. When we look at the raw values compared to the other big study, which was that study that looked across to CT values, they're actually quite comparable. And Carrie Earthman, who was on that paper, and as part of this, we've had a phone discussion in the last 2 weeks, getting very excited looking over this and trying to understand what it means. So we're still working through it, but we'll keep sorting through it. And if you've got any pearls, talk to us, and we'd love to hear your interpretation too. Yeah.
Any other questions? No?
Claire, given your results weren't consistent across the sites, do you think there is a risk that you'll find it, how much confidence do you have in the findings that you've presented?
To be honest, it's not overly strong. I think it's more about finding a signal and working out what would you need to troubleshoot. I think the hardest thing is it's retrospective. So the sample from Queensland and lots of my groups had very specific septic patients. I know for my sample that they had quite long admissions, so they were sort of, at least 2 or 3 weeks down the track, so they've lost that massive amount of muscle mass. They're possibly more chronically ill, so they're quite stable, whereas the Melbourne group, their average length of stay was 5 days. They had only 48 hours of mechanical ventilation. They're at that shorter end, so I think those fluctuations and where they are in that trajectory and what's going on challenges that. So I think that there's those cohort differences, and I think there might be some site differences as well. I think by the time you add up 1% of error here for using a different measurement for looking at a patient's height to put into those prediction equations, I think that's the trouble. I think if we had the raw impedance data where you don't have to worry about weight or height and you just have to make sure that you've got the limbs away from the body okay, basically, that you've cleaned the site and you've got the electrodes on. I mean, we're all physios, we're pretty good at surface anatomy. We should have been able to get those electrodes on, pretty nicely and consistently. I think that's where some of it might come in. So it is a bit messy. I have reserved confidence, but I think it's a signal that kind of fits with literature in non-critically ill patients, whether you look at dialysis, whether you look at cancer and things. And so I think it's got that contextual interest as a signal mainly.
So do you think we need to move towards a prospective data collection? Do you think that's warranted? I think so. I don't think, you've got other measures like ultrasound, which are clearly progressing, where the bioimpedance will be a tool for that. But I guess bioimpedance has potential, if they're doing it anyway, to look at perhaps fluid change after dialysis, then why not get some value out of it by understanding muscle outcomes? So I don't know that it's a tool that we'd focus on as a core thing for physio. I think work around ultrasound and what that means for your muscle strength and function will be interesting, but how we might piggyback on is I think the reality of where it will probably head. Yeah. Great. Thanks so much, Claire.
Thank you.